Secretary, I think we did recognize or acknowledge that Heather Saint is now board director. So I just want to reiterate that. Okay, thank you. And the next regular board meeting is scheduled for Friday, September 26th at 9 a.m. And then let's get to the most important thing on the agenda, employee recognition. Dr. Pettis.
Thank you, Chair Garza. Good morning, directors.
Good morning.
There you go. All right. So as always, we'll start with our new hires and our promotions, starting with new hires. Welcome to Grisel Soto, Senior Director of Health Protection with Public Health, and John Ruggiero, Section Head of Joint Combat Trauma Education and Training. And congratulations to our leaders who earned promotions: Darcy Moeller, Public Health and GPMRPD and Medical Officer with Administration; James Towner, Chair of the Division of Neurosurgery, and Carla Gill Cruz, Nurse Coordinator to Labor, Delivery, and Postpartum. Congratulations. And we'll shift to recognitions and announcements. And as always, if the team being recognized is in the room, we'd appreciate if you could stand so we could recognize you. So we celebrated on August 14th. We had our Cook County Health leaders, our elected officials, and our community members come together to celebrate the 50th anniversary of the opening of Dr. Jorge Prieto Health Center, Cook County Health's first community health center. Do we have anybody here? No? Yeah. We also earned 19 awards for excellence with the NACO program, including the Cook County Department of Public Health and County Care for outstanding programs and initiatives that serve residents across Cook County. I'm not going to read them all to you, but they are listed there. A lot of effort and a wonderful results with the 19 programs being recognized. Congratulations to everyone involved. We're also proud to share that Stroger was recognized by U.S. News and World Report as a high-performing organization for COPD, heart failure, and leukemia, lymphoma, and myeloma. The U.S. News and World Report's annual procedures and conditions ratings are designed to assist patients and their doctors in making informed decisions. Congratulations, team. And in addition to earning several American Heart Association Get With the Guideline Achievement Awards, Cook County Health received the Commitment to Quality Award. This is the first year for the special award level, and it recognizes elite groups of hospitals that have reached achievement levels in 3 or more Get With the Guidelines areas. There were only 158 sites recognized for this across the nation. Congratulations, team. We're also happy to share that Cook County Juvenile Temporary Detention Center again earned reaccreditation with NCCHC, demonstrating compliance with their nationally recognized standards of care for health services. This reaccreditation recognizes the ongoing commitment to provide quality health services for a very special population. Congratulations, team. On August 9th, thousands gathered at the Bud Billiken Parade to celebrate the start of the back-to-school season, and our team was proud to provide medical support along the parade route, and we also had 2 floats there, one for CCH Provident and one for County Care. Thank you to everyone who participated, whether in medical tents or on our floats. There's our participants. On August 13th, Cook County Department of Public Health held a press conference to announce they're launching a campaign to encourage parents to get their children vaccinated against measles. And on August 5th, we held a press conference to announce a $2 million grant to the Chicago Abortion Fund. The grant will fund clinical and wraparound services to ease the burden on patients who are seeking abortion care. Transportation, lodging, child care, and other social services will be funded by the grant. And our team with the robotic bronchoscopy cases at Stroger earned a milestone event. They hit their 100th case a full 2 months ahead of our projected timeline. Very grateful for the support from the entire team, including nursing and radiology, sterile processing, administration, pathology, for supporting the milestone. Congratulations to everyone involved. And this month, Cook County Health led a discussion in Spanish to reach out to our Spanish-speaking patients with critical healthcare tips for back-to-school season. The event earned over 13,000 impressions and reached 9,000 users on social media. Thank you to Dr. Monica Vanales, Maritza Guzman-Lariano, and Dr. Alejandra Cordova for a successful and insightful event. Congratulations to Ling Dang, who was recognized by Beckers as an outstanding Chief Experience Officer. She's making a meaningful impact on patient experience, and it was recognized as one of the leaders across hospitals and health systems nationwide. Congratulations, Ling. And congratulations to Ginsberg J.C. Thatchell for being recognized by Illinois Nurses Foundation as a 2025 40 Under 40 Emerging Nurse Leader. The foundation proudly celebrates his resilience, his visionary leadership, and unwavering dedication to advancing the nursing profession and patient care. Congratulations, Ken. I think that's for part 2.
Thank you. And congratulations to everyone, and really the great work that the county does every day to support the residents of Cook County. So once again, let's give them a round of applause. Thank you, everyone. Okay, we'll move to item number 3, which is I'm going to ask Madam Secretary if any speakers have registered to provide virtual or in-person testimony or have sent in any written testimony to be included into the record.
We do have several people signed up to give testimony, and we also have some written testimony, which I'll cover at the end.
Thank you.
The first speaker is Karen Felsenfeld. Yes. And just a reminder to the speakers, you have 3 minutes. I'll let you know when you have 1 minute remaining and when your time has expired.
Good morning, everyone.
Good morning.
Thank you so much for the chance to speak today. I am a senior staff attorney at Legal Aid Chicago, and we have a medical legal partnership, what we call an MLP, between Legal Aid Chicago and Cook County Health. Legal Aid Chicago is the largest provider of free legal services for low-income people in the Midwest. Our partnership with Cook County Health began in 2017, and each year we've served more and more patients who are referred directly from Cook County Health. The idea of combining healthcare and legal services began in the 1960s with Dr. Jack Giger, who went to Mississippi to provide healthcare to the Freedom Riders. He believed doctors should address both medical and social conditions affecting health, and famously prescribed food to malnourished patients, reflecting that belief that medicine could drive social change. In the 1980s, HIV and AIDS activists took on this approach by connecting patients to legal help for end-of-life planning and fighting discrimination. And later in the 90s, the Boston Medical Legal Partnership was born, where doctors, for example, one of the prime MLP cases is there were children coming in with asthma, and the doctors kept treating the children, and they would come back with the same problem. And so they connected with lawyers because what was really happening was there was mold in these children's apartments. And so they needed legal representation to fight against the landlords to get rid of those poor housing conditions. So medical legal partnerships like ours, they reduce hospital visits for chronically ill patients. They help ensure people take their medicine as prescribed. And often patients might not even realize they have a legal issue until they come in. Our MLP focuses on 5 key areas: reducing income insecurity and improving access to healthcare, preserving housing stability, ensuring fairness in employment and education, protecting those without legal status, and ensuring family stability. Health equity requires access to equal justice, but a huge justice gap exists here in the U.S., as you know. The American Bar Association reports that there are only 3 legal aid lawyers for every 10,000 people living in poverty in the U.S.
1 minute remaining.
Thank you. So our goal is to allow Cook County Health patients fast and streamlined access to legal aid's legal services through direct referrals. We work hand in hand also with care coordinators, nurses, and social workers to develop and advocate on each client's case. So just a quick insight into our numbers in my last little bit of time here. One of our biggest areas of impact is government benefits. In 2024, we secured $246,700,000 in benefits for our clients, either by helping them apply for these benefits or appealing wrongful denials. And regarding Medicaid alone, in 2024, we were able to keep or obtain Medicaid coverage for several clients, which resulted in an annualized benefit of $55,000 for those clients. And very quickly, I'll just share a really quick real-life story from one of our clients. We recently helped a client, Ms. H., who came from Venezuela, seeking asylum. We helped her apply for VTTC benefits, but DHS failed to act on her application. We filed an appeal and launched a broader advocacy effort to push push DHS to process these delayed VTTC application cases. As a result, she received food and cash benefits, retroactive payments, and medical coverage for herself and her baby.
Your time has expired.
Thank you so much.
Thank you. Thank you for that. Thank you for the work that you do.
Next speaker is Constantina Mises.
Good morning, everybody. My name is Constantina Misi, and I'm the president and CEO of the Latino Alzheimer's and Memory Disorders Alliance. Many people know the organization as Lambda. Lambda started from zero, like many other organizations in Chicago. We are historically fighters, right? So I just want to say, because the 3 minutes scare me, so I just want to say thank you. Thank you for helping us to serve the most underserved people in our communities. We receive funds from you, and with the funds that we receive, I just want to let you know that we educate exactly 6,774 individuals about COVID. Thank you so much. We enroll them, register them, help them to receive a vaccine. And we have 35, I just try to put everything together before I hear 1 minute. So 38 community health workers that work for Lambda actually work for the community, visiting laundries, visiting libraries, churches, schools, everything. They are on the streets. We had a budget of $2.2 million annually. I don't know how. Well, I know, but I don't want to extend it. In the last 6 months, our budget is $80,000. And if there is any organization that say that they are doing very good, I won't believe that. I won't believe that. So first of all, thank you. And second, keep us supporting the organizations. Because the non-for-profit organizations that are on the streets, what we see is that the worst thing that I saw in my life is a testimony from a woman who's taking the chemotherapy, and now she's afraid to go and refuse. I know, it's 1 minute,
1
right?
minute, yes.
Thank you. Okay. I'm monitoring her, actually. So she's not going to the chemotherapy because afraid of immigration, afraid of what. Doesn't matter if they are documented. They're talking about the color of the skin. They are afraid. So you have power, and you know where is your power. But there is one power, huge outside, huge. One power that is bigger than you. And I want to finish with this. The power of the fear. The power of the fear in our communities. So whatever you do is huge appreciated from our communities. Thank you.
Thank you. Thank you for your advocacy, your passion, and your impact.
The next speaker is Tal Hafak-Lawi.
Good morning, everyone.
Good morning.
My name is Tal Hazak-Lowy, and I'm the Executive Director of Friends of the Children Chicago. I'm grateful to be here today to share the impact of our partnership with Cook County Health and the Stronger Together initiative. At Friends Chicago, we intentionally serve the children and families facing the greatest hardships, which impacts their mental, physical, and social well-being. We do outreach to identify the children facing the most challenging circumstances, children who have experienced countless adverse childhood experiences. We receive referrals from the schools, DCFS, and community violence intervention organizations, among others. And we devote up to 3 months to gain the trust of a child's parents or caregiver so they voluntarily enroll their child in our program.
Children join our program in kindergarten, and we pair them with highly trained, salaried professional mentors. Every child receives 4 hours of one-on-one trauma-informed mentorship each week, year-round. Our mentors work across all aspects of a child's life, helping them build the skills, relationships, and goals they need to thrive. Our two-generation model also embraces parents and caregivers, providing support, referrals, and a community of healing and belonging. Here's what truly sets us apart. We walk beside each child and their families for 12 and a half years, no matter what. The work that our professional mentors do is not therapy, but it is therapeutic. Trauma-informed is not a policy we follow, it is the heart of our work. We provide every child and every family with a regulated, consistent, positive relationship. Someone who's there for them no matter what. Someone who celebrates when things go well, and an ally when challenges inevitably arise. It's this commitment that makes a difference for the children and families we serve. The results speak for themselves. 92% of graduates across our national network go on to enroll in post-secondary education, serve in the military, or secure full-time employment.
1 minute remaining.
Yep, the Stronger Together initiative is allowing us to enroll more children into this life-changing program. It is also allowing us for the first time to provide free on-site therapy for children, caregivers, and even our professional mentors. This matters deeply because the children and families we serve have endured exposure to violence, housing instability, foster care, parental incarceration, and more. 10% of our youth have lost a parent or caregiver to gun violence since they've been in our program. Let me share the story of Talia. She entered our program when she was in kindergarten and now is in 7th grade along with her 2 younger siblings. When their father was shot and killed, their mother's first call was to Friends Chicago. Our mentors comforted the children and supports the mother through a deep depression. We also knew that therapy for her and her children was essential, but wait lists, cost, and transportation stood in the way, and an even greater obstacle was her own fear. When we launched our in-house therapy program in a place she trusted, our clubhouse, she finally agreed to enroll her children. Today, all 3 children and their mother are attending therapy consistently. This partnership has given Talia's family and so many others a real chance at recovery, well-being, and hope for the future. Thank you for making this work possible and for standing with us to prove that we truly are stronger together. Thank you.
Thank you to Friends Chicago for all that you do for families who are at most risk. We appreciate your work.
The next speaker is Laura Finnegan.
Good morning, everyone.
Good morning.
My name is Lauren Finnegan, and I'm the Director of Behavioral Health Services for Metropolitan Family Services. I'm giving this testimony today on behalf of Megan Kelly. She's our Program Director for our Crisis Services at Metropolitan Family Services, and she leads the Stronger Together initiative. MFS has been serving individuals and families in Cook County in the Chicagoland area since 1857. I'm here to highlight how the Stronger Together initiative creates a unique opportunity for MFS to further our goal of greater awareness of crisis services in the Southland, as well as improve quality of care for those most in need. As a longtime provider of mobile crisis response, first a SAS provider, and now additionally with Program 590, MFS has an extensive understanding of the importance of services being easily accessible, supportive, and community-based. Our services are currently funded through a mixture of managed care billing, Medicaid, and grant funding, typically leaving little room in the budget to support things like awareness initiatives, workforce development, and business development. The introduction of Stronger Together allowed us to complement our already funded direct services with what are traditionally unfunded activities and strengthen our impact. Our goal of Stronger Together is twofold. First, increase awareness of mobile crisis services in our communities, including residents, public and private sector stakeholders, and local EMS. Secondly, better equip our response teams and community members with crucial skills to help people experiencing mental health crisis through training and evidence-based models. Through Program 590, there is still work to be done in alerting communities to the availability of mobile crisis response and go-to immediate resources. Depending on the community, even local first responders have varying levels of knowledge of the role that MCR teams can and should play in situations involving a mental health crisis. Stronger Together allowed us to hire a community liaison who leads awareness campaigns and fosters partnerships with vital stakeholders. Today, with our partners, we are able to define roles in the developing landscape of community crisis response and how we collaborate to improve the wellness to our clients. We're hoping to see a greater use of services, a more focused use of EMS, and more importantly, ensure that people who need mental health care are being met first by those with expertise in how to support them.
1 minute remaining.
Since implementation, we've already seen an increase in the use of our hotline, more awareness of 988, and have made significant progress in strengthening partnerships with police. Stronger Together initially hired a training coordinator who's been trained and certified in 4 evidence-based models focused on crisis care. These range in skills, population of focus, and response strategies. In the first 7 months, we trained approximately 120 individuals in various models, ranging from crisis intervention workers to staff at libraries, schools, and cancer treatment centers. Given the varied access to resources and training across the landscape, our team offers individualized options to partners based on their unique needs and wants. Our goal is to create aware, well-prepared, and compassionate communities for residents that need the most support. We truly believe that healthy communities require everyone to play a role in creating collective impact, and Stronger Together in Cook County Health has allowed us to get much closer to that goal. Thank you for your time, and thank you for your commitment to the community's partners and residents of Cook County.
Thank you, Lauren.
The next speaker is Asta Ziegler.
Good morning.
Good morning.
Thank you for the opportunity to speak today. My name is Asta Ziegler, and I serve as the Director of Clinical Services at New Moms, a nonprofit dedicated to supporting young mothers under age 25 and their children. Parenting is challenging under any circumstances. Parenting as an adolescent, without stable housing, financial security, or a strong support network is exponentially harder. That's why New Moms exists, to help young families thrive through housing, paid job training, family support, and other essential programming. Last year, we supported 835 young moms and kids, and let me tell you, the future of Cook County is bright with these families in it. When we received the Stronger Together grant, our mental wellness program was in its infancy, and the need for mental health support far outpaced supply. Funding from this initiative has made an immediate, measurable impact for the families we serve, enabling us to launch or expand behavioral health programming in 3 key areas. We expanded individual therapy for young mothers, increasing participation by 50%, while investing in training to ensure access to high-quality, evidence-based approaches. We launched a parent-child therapy program that strengthens caregiver-child relationships during 2 critical stages of development, early childhood and adolescence. We partnered with a psychiatric nurse practitioner to provide on-site assessment and medication management, creating a one-stop behavioral health access point where a participant can see their therapist, their psychiatric provider, and a coach all in one day with the added support of on-site childcare. This new programming is reaching families and making a real difference in their quality of life. Already, 88% of individual therapy participants report improved mental health, and among parent-child therapy participants, 89% report stronger parent-child relationships. While we're proud of these outcomes, the real impact of the funding we've received is found in stories of individual families.
1 minute remaining.
Mothers breaking intergenerational cycles, finding words for a lifetime of trauma, and reclaiming control of their stories. A mom who can now stay regulated to guide her nonverbal 4-year-old through episodes of headbanging, now less frequent thanks to therapy. A 17-year-old mom who has left an abusive relationship and now sets boundaries routinely. A 7-year-old who arrived with crippling anxiety and now plays soccer with friends and uses a mantra for herself: I can do it. And a mom who in a proud moment wrote this to her therapist: I trusted myself and stayed true to who I am. You're teaching me how to celebrate myself. Young families are taking powerful steps to break cycles and build bright futures. We are thrilled to continue this work for the next 15 months with your support. and we urge you to continue supporting young families in Cook County by funding these initiatives for years to come. Thank you.
Thank you, Asa.
The next speaker is Esther Corpus.
Good morning, everyone.
Good morning.
My name is Esther Corpus. I'm the CEO of Alivio Medical Center. I'm here to express my deepest support for the County Care Health Plan. Alivio Medical Center is a federally qualified health center. We've been in existence for over 35 years. We have 7 locations in Greater Chicago, Pilsen Little Village, Back of the Yards, West Lawn, and West Suburban Berwyn. We provide care for 25,000 unique patients a year. 7,000 of them are county care members, and about 7,000 plus are uninsured. And we are also the organization that founded Healthy Illinois, which is the first in the country to provide health care benefits for immigrant adults, and the first in the country to end the program, which I'm not proud about. Our population is uniquely diverse in allowing us to provide care to these very needy communities. Since 2014, Alivio has partnered with County Care through MHN ACO, a collaboration which is wholly owned by Cook County, FQHCs, and safety net hospital providers. This is a very forward-thinking model, excuse me, that creates many jobs for community residents, and which are disproportionately impacted in these areas. And so this is such a unique model that we have. And I have to say that this is only possible by your leadership here at this table. Protecting Medicaid right now is, there's probably never more of a critical time than today, as we know that we're going to be experiencing some federal cuts to not only Medicaid but to Medicare. This will definitely impact vulnerable communities like the communities that Alivio serves and FQHCs in general, and Cook County.
1 minute remaining.
Over the past several years, we have partnered with County Care to host community events, which offers culturally competent guidance and provides on-site assistance for redetermination. These efforts have helped 97% of eligible members to retain coverage, contributing to MHN's ACO achieving top performance in redetermination and outcomes. If I could just have a moment to share a patient story, one of which a patient, after 1 day of hospital admission for a behavioral health diagnosis, the parents of a 16-year-old received follow-up by our transition of care team. The Spanish-speaking parents disclosed that their child had a history of depression and anxiety, leading to physical symptoms, inability to focus, absenteeism, and overall performance in the classroom. Alivio's care management team provided ongoing follow-up care with Spanish-speaking adolescent psychiatrists, a behavioral health team for outpatient therapy. The parents and behavioral health staff worked with teachers, school counselors to identify the best options for this patient during this transition. It was decided that temporary homeschooling was the best for this patient and was certified to receive homeschooling. The parents and the behavioral health staff worked with teachers, school counselors to identify the best options for the patient during this transition. It was decided that temporary homeschooling was best for this patient and was certified to receive homeschooling. The transition of care model is so critical to treatment, but oftentimes in traditional settings it's overlooked, leading to breakdowns, fragmented care, hospital readmission, and ultimately increased costs.
Your time has expired.
So I want to thank all of you for listening to my testimony, and have a good day.
Thank you, Esther. Thanks for the work that Alivio does in the community.
The next speaker is Megan J-Lo.
Good morning.
Good morning.
Good morning. My name is Megan Jaifo. I use she, her pronouns, and I'm the Executive Director of the Chicago Abortion Fund, or CAF. I want to start off with so much gratitude for each of you here today and truly making history. Today will mark a historic investment in abortion access for the county, and this effort could not come at a more critical time. We see every day on our helpline what it looks like when people face barriers to getting basic, essential, normal health care. Every investment in the abortion access ecosystem right now is life-changing and potentially life-saving. CAF is Illinois' statewide abortion fund, and we are now the largest independent abortion fund in the country due to political interference in the lives of women and people who can become pregnant. We support people who need and want abortion care with funding for their appointments, individualized case management, travel and logistical needs, and emotional support. Since the Dobbs decision overturned Roe v. Wade over 3 years ago, we've assisted over 40,000 people facing barriers to care, with many of those relying on Cook County's compassionate and caring providers to get the care they want, need, and deserve. I want to note that compared to people who are denied the abortion they seek, people who receive a wanted abortion are healthier, they are more financially stable, they set and achieve more ambitious goals, they raise children under more stable conditions, they're confident their decision was right for them, and they're more likely to have a wanted child later on. We recently supported a young parent who couldn't bring her toddler into the clinic with her, providing in-person childcare so she could keep her appointment without worry. We've connected recently with a CPS student who didn't have family support for her decision to get an abortion, and we supported her emotionally and with rides from the clinic and finding an appointment that worked for her schedule. Another patient we recently cared for worked here in a local restaurant and was weighing paying rent or paying for her health care. We were able to cover the cost of her abortion and provide support with groceries so she didn't have to face hunger on top of everything else.
1 minute remaining.
We're in a moment of extreme uncertainty, but what we do know for certain is here in Cook County, we have an incredibly strong network, including CAF, providers, elected officials, and leaders such as yourselves that have been doing the work and continue to do the work to make abortion accessible for all. With this investment from the county, we'll continue to make abortion care not only an option, but something people can actually get to for thousands facing barriers each year. Thank you for investing in this work and standing with us. We are so proud to be a part of Cook County's long-standing legacy and commitment to bodily autonomy. We are proud to say that we're doing this work in a city, county, and state that invests in patient navigation to fill gaps in access. And we are so proud to be in partnership to ensure that these investments in access and legal protections translate into actual care for people who need it most, because health equity means every person, regardless of their income, gender, race, insurance coverage, or zip code, can get the care they deserve. Thank you so much.
Thank you, Megan. Keep fighting for people and women.
The next speaker is Tina Montanez. And for the record, I also have her testimony in writing, and it'll be included in the written testimony for today.
Thank you. Good morning, everyone.
Good morning.
My name is Tina Montanez. I have been a nurse at Cook County, Stroger for over 20 years. I work in the main operating room here at Stroger. I want to address the need to fill hundreds of nursing vacancies and the use of agency nurses. In the main OR, for example, due to short staffing, we rely on agency nurses to assist us. We have an agency nurse that has been there for over 2,200 days. This is far too long and unacceptable for a regular staff nursing position to be filled. As a union nurse, we are aiming to address the need to fill hundreds of vacancy nurse positions, and we think creatively how to move hundreds of agency nurses into these vacancies. Addressing these chronic intertwined issues will help provide safer staffing so that our patients receive quality and efficient care they deserve. Thank you for your time and consideration. Thank you.
Thank you.
The next two speakers are virtually connected, and the first one is Falguni Dave, and I also have her testimony in written, and it'll be a part of the record. Falguni, are you ready? You might be muted. Do you want to check your microphone?
Okay.
There you go.
Good morning. Good morning. My name's Falguni Dave. I'm a nurse on Unit 4800 at Stroger Hospital. I've been a nurse at Cook County for 13 years now. I'm the chair of our professional practice committee, and I have been recently elected to be on the bargaining team during this upcoming negotiations. Unit 4900 has been operating as a step-down CCU unit for over 1 year now. We still don't have guidelines for admissions to this unit laid out. Management has not met with union staffing committee to set up any staffing plans for this unit. 4900 has been operating all on agency staff. We need PID posted for all the vacant 4900 positions. A unit cannot and should not have been opened with all agency staff. Management needs to meet with union to come up with the best way to move forward on keeping 4900 operational, but with all or most permanent staff nurses. CN2 position has been given to a newly hired nurse and was not posted internally for senior nurses to consider and apply for. Also, Chris Yolo is calling her hand-picked agency nurses and offering them staff positions without PIDs being listed on the HR hiring site. All the above mentioned concerns are in violation of the CBA. Unit 4800, we still have multiple unfilled staff positions. Day shift needs a second CN2. There was one when we opened 4900 as IMCU over 2 years ago, but the second CN2 left and the position was never filled. There also been some discrimination in the hiring processes. There's a nurse in trauma who is a charge nurse, and her son was hired for a night shift on the same unit, but now has been transferred to day shift where she is his charge nurse. When my daughter applied in last January, she was denied the position, which she interviewed really well for because I was the charge nurse on the unit. Please explain where the transparency and equal treatment in the hiring process is. We have reached out multiple times to HR for answers, but still have not received any response as of yet. I want my daughter to be given the same opportunity as the son of the nurse who was hired for trauma. In closing, I want to say that nurses come and speak up, but we feel our concerns are never heard. This time, I would like to see some actions on the complaints that we made. Thank you.
Thank you.
Thank you. And the next speaker is Brenda Langford. Brenda, are you there?
Yes, good morning. My name is Brenda Langford. I am a registered nurse who has worked at Cook County Health for 27 years, currently in the county care department. I'm also a proud union nurse who has served on the national board for NNOC, NNU, and on the bargaining team. I come before you today because in preparations for the NNOC contract negotiations, we have reviewed budget information and NNOC RN statistics as of July of 2025. We have reported to this board of inefficiencies in the hiring practices, agency use, staffing shortages, and filling vacant positions across Cook County Health. And this board has previously acknowledged the value of decreasing agency use in hiring CCH full-time staff employees. NNOC Union has expressed our interest and support to improve CCH recruitment and retention practices. Our RNs are being blamed for inefficiencies in staffing conditions throughout the system. CCH has engaged in discussions with other unions regarding accelerated hiring processes to help with recruitment efforts and filling of their vacancies. As our union goes into contract negotiations, we hope to be able to discuss accelerated hiring processes and onboarding opportunities to convert agency RN positions into full-time staff to decrease the over 500 vacant positions in CCH. We have previously tried to be supportive by providing lists of agency nurses who have expressed to us that they are interested in becoming staff employees for CCH. And many of those agency nurses have actually applied for positions without receiving any sort of response from HR for interviews or offers. And we hope that the HR department is as committed to filling these vacancies as is this board. Our union is seeking to engage HR with unique opportunities to help recruit nurses to provide safe and effective care to the communities that we serve and retain those nurses in a manner that will extend beyond 2 to 3 years to improve the net gain of RNs at the bedside, leading to sustainable outcomes and fulfilling careers within CCH. Currently, 14% of RNs have had the honor of working for CCH for 25 or more years of service. And as of July 2025, there are more than 70% drop between the nurses who have been employed for 2 years or less as compared to those for 3 to 5 years of service. And there are agency nurses who have been contracted at CCH for 3 years or more who would love to become full-time staff of CCH. It is imperative that we work together to improve upon possible solutions to recruitment and retention for the long-term viability and services of CCH that we are all committed to. We look forward to having the opportunity to have meaningful engagement with HR during our upcoming contract negotiations to support the mission and the objectives of CCH and its health system. I do thank you for your time.
Thank you.
Okay, that concludes the oral testimony for today. So to summarize written, we have written statements from Falguni Dave, Tina Martinez, Brenda Langford, and Dr. Ngozi Ezike. They will be part of the meeting record.
Thank you, Madam Secretary. Thank you to all the speakers for giving very much critically important testimonials. I know some of those will have follow-up, so appreciate your time and your testimonials. We'll move to item 4, which are board and committee reports, and I'll present the minutes of the July 25th, 2025 board meeting. Are there any corrections that are needed? Okay, hearing none, I'm going to ask for a motion to approve item 4A, the board meeting minutes of July 25th, 2025. So moved. Second. Thank you, Vice Chair. Thank you, Director Harrington. Is there any discussion? All those in favor, say aye. 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 Any opposed? No, the motion carries. Thank you. We will now move to item 4B, and I'll turn that over to Director Bott, which will present that.
Thank you, Mr. Chairman. Quality and Patient Safety Committee met on Friday, August 8th at 9 a.m. Committee approved the following action items, which are included in the minutes. Approved 1 Stroger Hospital Division Chair initial appointment, 1 Department Chair reappointment, 1 Division Chair reappointment. Approved Stroger and Provident Hospital medical staff appointments, reappointments, and changes. The committee received the following reports, which are included in the minutes. Operations Excellence Dashboard Goals and Tactics, Report on Activities to Reduce Sepsis, Quarterly Grievance and Patient Experience Report, and a regulatory update. The next meeting of the committee will be held on Friday, September 19th at 9 a.m. There are no other questions on the minutes that are being presented for the board's consideration at this time.
Thank you, Director Bott. Is there a motion to approve item 4B, the minutes of the meeting of the Quality and Patient Safety Committee of August 8, 2025, which included approval of the following items. Item 1, proposed Stroger Hospital Division Chair initial appointment. Proposed Stroger Hospital Department Chair reappointment, and 1 proposed Stroger Hospital Division Chair reappointment, and the Stroger Hospital and Provident Hospital medical staff appointments, reappointments, and changes. Second. Thank you. Is there any discussion? Okay. All in favor? Aye. Any opposed? The motion carries. Thank you. We'll move to item 4C, minutes of the August 5th, 2025 Finance Committee special meeting, and I'll turn it over to my colleague, Director Ryder.
Thank you,
Mr. Chairman. The Finance Committee convened a special meeting on August 5th for the purpose of introducing the proposed Cook County Health fiscal year 2026 preliminary budget and conducted public hearings. I want to thank Commissioner Lowry, who filled in for me at the start of this process on August 5th. The meeting was reconvened on August 11th and August 13th for public hearings. At the public hearing on August 11th, 10 members of the public provided testimony and 3 written testimonies were submitted. At the public hearing on August 13th, 5 members of the public provided testimony and 1 written testimony was submitted. The written testimonies submitted are included in the minutes and are a part of the meeting record. This meeting was held for informational purposes. There was no action items considered at this meeting. If there are no other questions, the minutes for the August 5th, 2025 Finance Committee special meeting are being presented for approval.
Thank you, Director Ryder. Can I have a motion to approve item 4C, the August 5th, 2025 Finance Committee special meeting minutes?
So moved.
Second.
Thank you. Is there any discussion? Okay, all those in favor say aye.
Aye.
Any opposed? Hearing none, the motion carries. We'll move right into minutes of the August 15th Finance Committee meeting, which will also be reviewed by Director Ryder.
Thank you. The Finance Committee meeting met on Friday, August 15th at 10 a.m. The committee considered the following action items, which are included in the minutes. Conditionally approved 13 contracts for procurement items numbers 3, 4, 6, 8, and 9 are pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose fiscal impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award related items. We approved the Cook County Health fiscal year 2026 preliminary budget. We approved proposed 3-year financial forecast for the Cook County Health fiscal years 2026 through 2028 strategic plan. The committee received the following reports, which are also included in the minutes: reported July financials, monthly report on agency reduction plan. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Director Ryder. I'll ask for a motion to approve item 4C, the August 15th, 2025 Finance Committee meeting minutes, which contain the following action items. Conditional approval of the contracts and procurement items pending review by contract compliance, and receiving and filing of the grant award related items. Approval of the proposed Cook County Health fiscal year 26 preliminary budget, as well as the approval of the proposed 3-year financial forecast for fiscal year 2026 through fiscal year 2028 strategic plan. Can I have a motion, please?
So moved.
Thank you, Vice Chair.
Second.
Thank you, Director Harrington. Is there any discussion? Okay, all those in favor, say aye.
Aye.
Any opposed? Hearing none, the motion's carried. We'll move to item number 5, action items, besides meeting minutes, and this will be consideration of the proposed Cook County Health fiscal year 2026 through fiscal year 2028 strategic plan. There will be no presentation or review, but here, actually, I'm going to ask Dr. Makaitis to just give a little bit of an overview or an outline of the process, because I think the process, it's important to understand the process to understand how we arrive at a very thoughtful and I think impactful strategic plan for that 3-year period. Dr. Makaitis.
Thank you, Chair Garza. Good morning again, directors. So as you've come along this ride with us, I'll just kind of recap what the process has been. So we started in January and had a lot of informative presentations, including and not limited to a public health scan, a market scan, governmental landscape assessment, and a review of service line strategies. We held town halls, we had advisory group meetings to get community and employee feedback. And as I'm sure you remember, we repeatedly brought the plan back to this group to review and receive feedback as well. So some of the key points that have come into the strategic plan: greater emphasis on access to care, on value-based care and population health, increasing focus on CCH core functions, process improvements, around improved hiring, improved procurement, and then leveraging benchmarks more robustly so that we're actually using data to drive decision making more effectively. And then including enhanced supports for members and patients with redetermination and insurance issues as we move into the implementation of HB1, and then ongoing contingency planning for resilience. So those are some of the highlights, and I'll hand it back to you, Chair Gallagher, for the vote, I guess.
Thank you, Dr. Markaitis. Once again, I want to thank the staff, Andrea Gibson, who really spearheaded the effort to make it a very comprehensively inclusive process centered on engagement and really listening to individuals at all levels and the community especially. So thank you for that work. So at this point, we are presenting that strategic plan to the board for your approval, and following approval, the proposed strategic plan and 3-year financial forecast will be presented to the Cook County Board for their consideration and approval. So at this point, I'm asking for a motion to approve item 4A, the proposed Cook County Health fiscal year 2026 through fiscal year 2028 strategic plan.
So moved.
Second.
Thank you. Is there any discussion? Okay, no discussion. All in favor, say aye.
Aye.
Aye. All those opposed? Hearing none, the motion has approved, and this will go forward to the Cook County Board. Thank you. Item 5B, contracts and procurement. None are being presented. Item 6, a report for me. I don't have one. I just really enjoyed the opening of this board meeting and really listening to the recognition of the good work that your staff are doing, Dr. Markaitis. So thank you for continuing to support them in a way that puts out the best work for people we serve. And with that, I'll turn it over to you, Dr. Markaitis, for your report on item number 7. And Dr. Markaitis will review, update on the ARPA obligations, and then introduction to the CIRMAC Health Services.
All right, thank you again. So we, I think, are just receiving the ARPA update at a high level. We anticipate being 50% expended by next month. So we're on a good track to be fully expended by the end of calendar year 26. So, and with that, I can hand it off to our CIRMAC team for a CIRMAC update. As Manny's coming up, this, as you probably remember, you used to receive a lot of packets of the various kind of divisions within the health system. This is a new approach that we kind of talked about, and we're going to be presenting directly to you to provide those updates in person. So this is our CIRMAC update.
Good morning.
Good morning.
Morning.
With me today, I want to make sure I acknowledge Dr. Augustine Ware, our Chair of Corrections Health, and I also have Mary Marcelo, our Chief Nursing Officer for CIRMAC Health Services. I myself and Manny Estrada, I am the Chief Operating Officer for CIRMAC Health Services. I've had the honor and the privilege of working with the organization for 30+ years at this point, so thank you for the opportunity to present who we are. A little bit about us before we get into the formal presentation. The organization that you see before you today is a different organization than it was 10 years ago, than it was 5 years ago. I've had the privilege of seeing this organization mature to what we have presenting in front of you. So we'll start off by telling you, CIRMAC Health Services is the nationally accredited, right, via NCCHC for jail standards, provider of healthcare services for those individuals in custody at Cook County Jail. Individual in custody is the naming sequencing that DOC uses for the folks at Cook County Jail. For us, they're our patients. We have the responsibility for providing services for all patients at Cook County Jail. In addition to the national jail standards, we are also accredited for our opioid treatment program and aligned with our strategic goals for 2025 going into 2026, are applying and expect to get our accreditation for our mental health for NCCHC, which will position us to be in a place to receive the Pinnacle Award for NCCHC, which is the national accreditation body for corrections health. So something that we're striving to in alignment with our strategic goals. We represent the intersect of healthcare for the Cook County Health aligned with the criminal justice system. So we meet in the middle. We provide primary care services, specialty services, mental health services, aligned with an additional series of service lines that Dr. Augustin will be able to talk to a little bit or speak to a little bit more in the presentation in itself. We have on-site 24/7 urgent care. We have on-site pharmacy services, and we have some diagnostic services. Again, in the presentation, you'll be able to see the work that we do in volume and in scope and breadth. In the case where we have patients that need a higher level of acuity and or specialized services that we don't provide at CERMEC, we primarily utilize Stroger Hospital and or the specialty clinic and or the nearest facility based on the patient's urgency and acuity. The pathway for patients that are entering the system start off with a patient being arrested in the community for the charge that is the charge. That patient presents in front of the Cook County Criminal Court System, which makes a determination whether or not to remand the patient to custody. One big difference that has taken effect since 2023 was the introduction of bail reform, which no longer requires cash bail to maintain yourself in jail. So the folks that are in our facility are folks that have been remanded to custody based on the acuity of their crime and or their perceived safety to the community and or themselves. When a patient comes into the facility, the patient goes through a series of screenings and or assessments. The first assessment is done by our custodial partners. They classify the patient based on, again, their previous history, presentation, charges to a level that's a custodial level of care. We, right immediately after that evaluation, do a Medicaid applicability assessment for the patients. We're one of the few organizations in the country that do that. We determine whether or not a patient either has Medicaid and or is applicable for Medicaid. In the case where the patient is applicable for Medicaid, we do our due diligence and provide them the opportunity to enroll in county care, which is our MCO, our Medicaid program. After that's done, we do a full assessment on the patient to include medical, to include mental health, to include pharmacological, to include socioeconomic needs, to determine what are the needs for that patient as they enter the facility to begin and or continue with whatever services the patient needs at that particular point. After the entire and mind you, this is all done within 24 hours. You'll see a little bit more on data, but we have between 80 to 100 new patients entering the facility every single day, 365 days a year. After all those determinations are made, the patients are housed in the facility and or location that's appropriate for their treatment, both custodial and for medical. Ultimately, the goal is to make sure that we treat the patient and prepare for the patient's discharge, because the patient will be discharged at some point relatively soon after their incarceration. A big difference between us and a state and or federal facility is that we're temporary housing. We expect our patients to return back to society, and a good portion, 90 plus, will return back to the community in a relatively short order. We are waiting adjudication for our patients. Next slide, please. This gives you an overview of what the campus looks like. We are the largest single-site jail in the country. Yes, New York is bigger. Yes, LA is bigger. Not that we want to be the biggest, but we happen to be the biggest in geographic area for a single site. We span approximately 100 square acres. On the left, you have Sacramento. On the right, I believe it's, I forget the street, but it's there, 26th on the top and 31st on the bottom. We are smack in the middle. That's the CERMEC building. It is also the CERMEC organization. We have approximately 10 buildings where we provide services, and you'll note during our conversation that a lot of our nomenclatures are paramilitary because the organization is based on paramilitary structure. By that I mean the DOC organization. We replicate some of the naming sequencing. For example, a dispensary for us is a clinic. An infirmary for us is a higher level of care. Sick call is where patients come to be seen by providers. Next slide, please. This gives you a picture rendition of who we are. On your left, you have the CERMAC building proper. That is where we have the highest level of care for our patients, the highest security. We have approximately 100 beds for medical and approximately 100 beds for mental health. They're at capacity most of the time. Next, you'll see the residential treatment building, which was built in 2013. At the point it was built, it was state-of-the-art. Continues to be one of the newest buildings we have on the campus. It is a dorm-type setting. You'll see the layout on the picture on the right. It's not conducive for epidemiological issues like COVID, which is what caused some of the issues that we had with the spread. We're also responsible for the Juvenile Detention Center, which has approximately a 300 patient census right down the street on Hamilton. And this gives you a sense of what a dorm is versus a cell setting. We have both in the facility. Next slide, please. Dr. A, if you want to be able to speak to a little bit about some of the services.
All right, thank you. My name again is Dr. Priscilla Ware. I'm the Chair of Corrections Health for the Cook County Health System. We wanted to give you a quick pictograph of some of the services that we give in the Cook County Jail compound. To align you with what's on the screen for you, is on the left side, you will see the locations. We call them live-in units, so this is where most of our patients reside. And then we have it by, if it's male or female, there's only one division on the compound, which is for females, including what we have on our CERMAC, inside our CERMAC building for females living inside the jail. As Manny talked about, we have classifications for our patients, M level being for medical, P level being for psychiatry, and we go from M2 through M4 and replicate it on the mental health side, P2 through P4. P4 being the highest level of acuity, M4 being the highest level of acuity. On the picture, you will see where we provide primary care services, mental health services, dental services, MAT, which is our substance use disorder OTT program, and then our medical detox is mainly in our RTU building, which is the newest building on the compound, and as well as nursing services, which our chief nursing officer here, in collaboration with the whole team, is responsible for. You see some of the on-site services that we provide. It's a wide range of services that we provide for our patients in custody. Pharmacy is a on-site pharmacy, physical therapy, podiatry, radiology services, which is CT and X-ray, respiratory services, lab services, infectious disease, which is really important in the correctional health setting, oral health, as mentioned, cardiology from our Stroger Hub, specialty care, optometry, which is on-site as well, and nursing care. Next slide, please. We wanted to show you a snapshot of some of the key volume services that we have on the compound. And this is as soon as from July 2025. So you will see that in July 2025, there were 6,490 medical encounters on the compound, over 5,000 mental health, over 5,000 health service requests. And these health service requests are done through nursing, and this is how nurses assess patients on the compound through triage, through sick call, and then they're able to route those specific patients based on their needs to a provider for a provider to see those patients. You can also see that over 1,800 specialty on-site encounters just in the month of July, and over close to 14,000 mental health encounters. So as you can see, it's really huge on mental health on the compound. About 40% of the population on the Cook County Jail compound is on the mental health caseload. We had over 500
close to 600 oral health encounters, and off-site coming from, the Cook County Jail to Stroger was about 325, and really impressive medication doses administered over 260,000. Next slide, please. Just a quick snapshot. You can see what the average daily census usually is. We're approaching 6,000. Today we were over 5,900. And so this is from the month of July, but as you can see, we continue to go up there. Our new admissions only in the month of July was close to 3,000. Our average length of stay is about 35 to 39 days, and the average age, as you can see, is 34 years old. A snapshot of what the population looks like, it's about 69.7% Black, 20.6% Latino, white is about 8.4, Asian 0.5, and other is 0.8. Just a quick snapshot. This is just a snapshot of what we have for chronic disease prevalence on the compound, just a replica of what's in the community: diabetes, asthma, COPD. Next slide, please.
I'm sorry, can I ask one question here? On the 5827 population that we have on daily census, are those unique?
Yes.
Yes.
So if we look across the span of 12 months, are we saying that we do not have repeat typically within the 12 months? Repeat, people coming back in. So I was arrested in January, and I got out, now I'm back in July.
Those are analysis that we try to do on a regular basis. We do have some folks entering the system. We wouldn't be able to provide that right now, but it's something we can definitely look up. But our average daily census runs about 6,000 at this point.
So this is unique, yes.
That's inpatient and outpatient? They're all outpatient. We have an infirmary level of care that's not an inpatient level, but it's, yes, they're both in the infirmary and across the facility.
And 40% of that population is mental health.
That's
Yes.
correct.
We are one of the largest providers of mental health services in the state of Illinois. We have been for quite a period of time. The reality is, the system is aligning services outside the community. Personally, my opinion, we dedicate where we need to dedicate services, right? But we're better served taking care of the community, and that way we deal with the mental health issues or mental health diagnosis, possibly minimizing the need for folks to reside within the facility. A little bit later, we'll show to you what the population shift has been since bail reform, and you'll be able to kind of glean additional information. But the system, to its credit, with the leadership from Dr. Makaitis, is building up a service line outside our organization.
Okay, well, you just took me where I was going to go later. And so since we're there, 80 to 100 people per day coming in, and they're screened. 90% return back to the public. So if we got 40% that have mental health, when they get discharged, where are they going?
Well, we have, and the presentation in itself won't give you the detail, but I'll give you at a relatively high level. Embedded within our organization, within CIRMEC, we have the equivalent to case managers. We call them psychiatric social workers, which are charged with making sure that we transition our patients back to the community. Our goal is to make sure that we prepare for your discharge, because your discharge is coming. So we do our due diligence to identify those that have serious mental illness, to make sure that we have a handoff, a soft handoff to organizations that have a relationship with. To the credit of the system, they've built up the ability to receive some of these patients. And we also deal with the folks that have a chronic medical condition, those that enter the system and have a condition that we need to follow up with. We also provide as best as we can with the relationship that we have with our affiliates within the county and with other community partners that we have. We have a rather robust network of folks, always willing to add more people. And in the presentation in itself, you'll see opportunities that we have there.
And you said the average stay is 39 days?
Yes, sir. Average is an interesting, it's the average, right? You have outliers, those that stay a lot less and those that stay a little bit longer. We have folks that have been there for years, but we have folks that leave within 2 days.
You have people that have been in jail for years?
Yes, sir. It's the criminal justice system that allows and affords people the opportunity to navigate the system. It's cases that we don't control. It's the criminal justice system.
Can I ask a quick question? So you have case managers who prepare for discharge. Do you have a, I don't know, like database or something that you actually share data with, providers outside of the jail to receive?
So one of the things that we have to our advantage, and we are really a unique system when it comes to corrections health, we have a lot of things that other folks wish they had. First and foremost, we have an electronic health record. Not every correctional health system that's in the country has that. Ours happens to be in alignment with the rest of the system, so we all share the same electronic health record. That information exchange makes it easier. With that electronic health record, we're able to share that information appropriately with partners that we have, maintaining the appropriate compliance standards that we have. But to answer your question, yes, we can share that information, and we do as appropriate.
Thank you.
Good. I have a number of questions. The first one is, you talked about mental health, and behavioral health are used interchangeably. So behavioral health is really focused on people that are abusing substances, making bad judgment. So what is the total number? What is the breakdown between mental and behavioral health? People that are there because of some type of substance abuse.
Well, I can tell you that we have, first and foremost, just again, reaffirming that we have an accredited opioid treatment program. That program, just at again, a high level, is maintaining folks that are in the community that come into the organization that are on a program, specifically methadone and Suboxone. We maintain the patients. We do not detox them. In addition to that, we induce, which means we begin treatment on folks that express an interest and a want to begin into the program. Approximately, I believe it's at about 170 patients that we have on that caseload now, always looking to expand. We look to leveraging the resources that we have in the system, leveraging the resources that are out viable for us. So, for example, we are able to activate some of the funding for the opioid settlement funding that are out there. We're able to secure medication. We're working on securing equipment. We're working on, hopefully, being able to augment the staff because, frankly, the resources that are available is what allows us to be able to induce more patients. We probably have folks that are out there that we have an opportunity to, but our capacity is based on what resources are available at this point. But we're always expanding. We're better now than we were a year ago. We're much better now than we were 10 years ago, and we're much better than most of the organizations in the country.
And we do make an effort, once they're released, to refer them someplace to continue to get whatever care they need.
Yes, there's a warm handoff to patients, for patients going back into the community where we send them back into their methadone clinics that they were at before, or we hook them into a methadone clinic, or send them to a provider who's able to give them any kind of MAT services. Our system has been very good that we're able to even transition people who were not in the program when they were on the compound to be able to go and start their journey with the Bridge Clinic, which is available to everyone. Yes.
One of the things that we struggle with is not bragging about the things that we do. We do some things really well. A patient that comes in on a program that's already established, the next day, not the following week, not 2 weeks down the line, the next day we're able to validate what their level is, what's going on with their programming, what's going on with their medication, and we're able to continue that. That's what the nature of our OTP program is, to maintain what our patients are in the community.
Yeah, and I have one more question. You see both male and female and adults and youth. Do you segregate them in terms of their visits and where they're seen and who sees them?
Sure. I can tell you the segregation and the housing of folks on the facility is absolutely specifically a DOC responsibility, but DOC does segregate by gender and does segregate by age. Our age at the Cook County Jail is 18 years and over. Juvenile detention generally is 18 years and younger. And that's the bifurcation of the patient population.
What percentage is 18 years and younger?
The population is under 200, probably about 170 at the Juvenile Detention Center.
Thank you.
I have a couple questions. It's good to see you again.
Thank you.
So I've been told, and I've even seen in print, that about 49% of the individuals being detained in Cook County Jail have been determined to have a mental health concern. Is that a fair percentage, or is it higher, is it lower?
It's somewhere within that radius. It's probably between 40 and 49. When we screen and we identify and we provide a level of care, we see it at a little bit over 40%, probably closer to about 43%.
Okay. And when I was last in jail, I was talking to a young man who said, one of the problems that have, I guess, fostered recidivism is when individuals return home, they may have a job, they may have transportation, they may have housing, but there seems to be a pause relative to their mental health care and their treatment. And when I spoke to the sheriff about it, he says to the extent that that's accurate, there's a connectivity issue, staying in touch with individuals once they go home. Is that your perception? And if not, I'd love to hear that it isn't.
We would love to continue with the case management of patients once they leave the facility, but the reality is we're finitely limited. Once they cross the threshold, we utilize our partners. We hope that our affiliates on the ambulatory side and or on the specialty side are able to continue with whatever course of treatment we begin with the patients in the facility. We also have a network of other community partners. Again, we're always looking to increase that. At the end of the day, and this is in all frankness and no disrespect to anybody, we are the medical and mental health providers, and we should be driving that. And we are driving that. And we're always looking to expand that. We will and welcome everybody that comes to the table to be able to meet the needs of our patients, because they're all of our patients. It's the community's patients. Right. Is there a struggle? Sometimes. The reality is we can always do better. The reality is that we have opportunities moving forward. And again, in the presentation, I'll briefly touch on the 1115 waiver, which is where we feel that there's an opportunity for us to increase what we do now.
Approximately how much notice would you say on average do we receive relative to an individual leaving Cook County Jail and going back home?
Very little. The only time we know a patient's leaving factually is when the patient has been remanded to custody at Cook County Jail, which is a small percentage. Generally, if you're in the jail, you serve under a year time, so we know when their discharge date. 95 plus of the patient are awaiting adjudication, so it's a potential anytime they present in front of a judge that the judge is going to release them. So we have very little. That's one of the reasons that we plan for their discharge as they walk in the door.
And last thing, I'm just wondering, would it make any sense at all to bring some of our bridge partners into our facility so that a relationship can be forged before an individual leaves?
We absolutely, we have that already to a certain extent. We, for example, are discussing with Family Guidance, which is a wonderful partner that we have, on introducing him into the organization.
Excuse me, I think a party just broke out. Go ahead, please.
Like that, we also have with our county care partners, we have individuals that are coming in looking at the housing needs, looking at your socioeconomic needs as you're in the facility. So we have that to the extent that we have now. Again, always looking to build that up. Without belaboring the point, 1115 will be able to hopefully, knock on wood, support some of the services that we're doing now.
If I may add, some of the things that we've put in place to be able to catch those people that we don't know are leaving the compound and will need services beyond us, really care coordinating them at the forefront. One thing that we embedded into us, in this past, we used to depend on the sheriff's department information for giving us info about phone numbers that we could reach patients for. Now we're actually asking patients who are sitting in front of us in intake, saying, you know, when you get out, how do you want me to reach out to you, right? And we've been able to embed that into our health records to be able to reach patients. Good. We have care coordinators on the compound who are actually meeting them while they're incarcerated to have discussions about what their needs are going to be when they get out. For medical folks and for mental health folks, we have built into our health records a way of actually putting in an order to say needs clearance before discharge, right? So a provider will be able to engage with them and say, you need medications, you need these appointments that you need to follow up with. And we have reports that print out every single morning, letting me know, this person got out last night at 3 a.m. You need to reach out to them.
By policy, we've codified some things, and by practice, we've codified some practices. So, for example, somebody on our mental health caseload that suffers from serious mental illness, we have an obligation to provide a bridge of medication. For those on chronic care, we have an obligation to provide a bridge of medication. We provide a 30-day supply of medication to bridge the patient until they can connect to their outside provider. We also do that in alignment with what Dr. Augustin described, just the case management or the care management. I'm using the terms interchangeably, but the roles are what that purpose is. I'm an old hospitalist. I used to work in a hospital as an administrator, so old habits are hard to break. My training was you always train and you always prepare for that patient to leave. The care doesn't stop when the patient leaves your door. You have to continue and always prepare for that. That rings true for us with the 5,000, 6,000 people that we have there. Our goal is to make sure that we not only take care of them there, but prepare them for their imminent return back to the community.
Thank you both.
You're very
So
welcome.
Chair Garza,
Sure, go ahead, Doctor.
one of the things that, I know you all do that helped, and I can't tell, no, it helped when I was at the Core Center Continuity Clinic, but it also had a form of it when I was at another FQAC. And so, yes, I'm a Dr. Zalis baby. But, it functioned like almost like a hospital discharge, where you all would let us know, even at the FQAC, which is an external institution, like, hey, so-and-so's here, you know. And then one of the disconnects I saw was what you said. The person would go before the justice system, and you're planning it in the background, and then the person just doesn't come, you know, just goes and doesn't come back. So when that would happen, I know someone, I'm not sure who, would reach out and say, hey, Maya Green actually left, and that would trigger our case manager on our side to get in touch with Maya Green and set like a 7-day. We were trying to set a 7-day appointment, almost like a hospital discharge. Mm-hmm. And I know that when I saw the transition from a former system to that, it really helped in that continuity of care. I don't know if you're doing that, but I knew you were doing that in the field of HIV. I don't know if you would, you know, that helps with the behavioral health and mental health too. That may help.
We do a lot, and we really are forward thinking in a lot of the work that we do, because we know these are our patients. Again, I don't want to brag about me or talk about me, but I used to be an ambulatory administrator. I met one of my colleagues here. I used to manage the Northwest Cluster for the Ambulatory and Community Network. So I know it's our patients that are out there. We always have to prepare for the patients returning back. We, for the Core Center, for example, have a group of folks that are embedded in CERMAC that look at the infectious disease component and follow up on those patients, not only with the Department of Public Health, but with their needs and care subsequent to their admission. We don't leave them and just go. We have that built into a lot of things. Again, it always can be better. We always strive to do better. And we will look ultimately to be, again, in my opinion, the example by which corrections health should be measured, because we are at the cutting edge when it comes to a lot of the initiatives that we have in this system.
Thank you.
Next slide, please.
Hold on.
I'm sorry, one more question over here, Chair.
Yeah. Go ahead, sir.
Okay. I'm struggling, because your program sounds like it is absolutely fantastic. But as Commissioner mentioned, when they leave and you're giving a warm handoff, but yet if you don't see your 40% reducing, and if we see them coming back, there's something missing here. Mm-hmm. That's the part I'm trying to get to, because I don't think you can do any more than you're doing, honestly. But what happens that they get outside and then they're dropping this because they now have something that we all cherish, freedom, and I can choose to do what I want to do when I want, and I don't do it? Your opinion, because you're in an extremely good position, because in an ideal world, if this was utopia, you would actually transition them to, say, Stroger, and you're doing it to county care, and then, okay, they have the insurance, they have the medical care, and now they're getting better. but that's not what we tend to see when we look at the numbers. So I'm trying to figure out where we're missing it, not being able to capture them fully at Stroger or Providence, and county care being able to now be able to have them under good control and giving them the case manager so that they don't now find themselves in a bad position.
Well, I can tell you again, I'm an old timer. I know, I've lived this life to a certain extent, to being able to see how it was. We as a society have opted to shift. Back in the 80s, when we were bringing down all the mental health opportunities that we had at the federal level, right? All that went down, and we saw the increases in the populations in the jail. That was directly related to not services being available in the community. We progressively have changed to understanding, in my opinion, where the resources, although I appreciate it in our organization, should be and are better suited sometimes in the community. I shouldn't be the largest mental health provider in the country or in the state of Illinois. I should be the supportive. But the reality is we're dealing with what we have now. I credit our health system for understanding that and looking to build up the service line, but we're one component. We rely on other community partners who are also struggling with making sure that those mental health services are available to the rest of the population. I look to a day when hopefully we right-size it and everybody that needs access will get. Some of the things we control, some of the things we don't, but we'll continue to do the work that we can to make sure our patients are safe and do everything we can, hopefully to not have them return back to us.
And if I may just add, I think the biggest component here is the care coordination piece. And that's where we need to look to really continue to make it robust, right? We struggle in that sense of resources. And I think what's about to come up with the 1115 waiver will really help strengthen that piece for us to put our arms around people who get out into the community and try to reduce the recidivism. Because recidivism is what's contributing to the over 40% that you have on the compound every day.
But if they are returning, then that seems like it's indicative of they're not getting the care once they leave you. Unless there's something I'm missing here.
No, I think you're spot on. I think it's less of a temperature check of how the team at the jail is performing,
Yeah,
more of a comment on.
They are the role model.
Right, well, oh, absolutely, but I think it's more in terms of kind of the ecosystem and what's available to patients. The fact that 40% is not getting better is a temperature check on what's available in the community for the patients to engage. Do they have
to provide a historical context. I was working for the city when the former mayor closed down all the community mental health centers that were operated. And so there are fewer resources available at a community level than there were when there were local places that people could go and get the services. And it doesn't mean that the number of people that need those services decreased. It just meant there were fewer resources for them to access on a community level.
Correct. Thank you for that clarity.
And I think this kind of dovetails with what the discussion is. Thank you for rising to address not only the systemic issue that you mentioned from the federal level, which basically closed institutions regarding that, and then the lack of funding that never reached the community mental health center level. And what funding did occur was also affected and impacted, which is the reason that we're seeing 40% of those that are currently in the carceral system with mental health issues. And we know that behavioral health and substance use disorder services, the majority of people with substance use disorder had a behavioral health issue, and because the infrastructure wasn't there on the outpatient system, many people begin to self-medicate to control those mental health systems. So it's not always necessarily a choice, but a systemic issue that was occurring on the outside. And we all know it's easier to find a liquor store than to find a therapist. So thank you for trying to work to support that. And we know that reentry services are really just starting to get some level of funding and identification of the need for having that smoother transition. My question is, given that you have 15,000 encounters in 1 month, that shows that you're providing the trauma-informed care, you're addressing people where they're at, and you're recognizing people as persons and not necessarily those that are incarcerated. One, are the outpatient referrals and systems that you're trying to transition to, are they also providing that trauma-informed care? Because certainly, many of us know, and particularly culturally, we've been potentially victimized or taken advantage of, and there's there's a cultural stigma to utilizing behavioral health services too.
Correct.
Are we reviewing those community partners to make sure that they're maintaining the standard that you obviously are, since they're continuing to come to see you? And then second, do we have to discuss, should Cook County, which has that health equity and trauma-informed care, should we rise to make sure that we may be the larger provider when persons are transitioned to reentry, so they leave our care and trauma-informed and continue with us on an outpatient service so that we can truly engage them, which has never really happened in our system?
Those are excellent questions. At the end of the day, we as a system, because the system does rely on the equity and the trauma-informed aspect in healthcare, we as a system understand the importance of it, and we believe and we work on making sure that's embedded into our practices. With our partners, we hope that they also follow the mantra and follow what it is. We rely on partners because they are the subject matter experts when they come on the outside, and this is not unique to the county, right? It's something that I believe that most of them may. Again, I can't speak to every single partner, but my hope is that it's embedded in there. We vet some of the folks because we have relationships with them, and we wouldn't begin a relationship with somebody that is not a good organization. But there's other organizations out there that we may not know. The network is large, and we do our due diligence in making sure we partner with good organizations.
That's going to be very important. There are many halfway houses that are abstinence only. So if you have someone stable on their buprenorphine or methadone, they're transitioned to reentry to a facility that states, okay, you have to stop this medication, and so of course then they fall off. Do we have a standards, or do we have a list or protocol for what are our more prudent partners to be able to work with in the community? Yeah. Or have we discussed potentially increasing the services that we can provide? Because that reentry service still is sorely lacking, and I'm hearing that consistently from our questions.
Agreed.
Yeah, definitely agree. I think one of the things that comes up, the sheriff also has these court ordered programs that they send people out to in the community as well. And we have a really good collaboration with the sheriff's department as well. That when we start to see people coming back into the jail for specific reasons, who have been in specific halfway houses, we're able to go back to them and say, please reevaluate your contracts with these specific people. So there's dialogue in there. Yeah.
That's important. Yeah. And then provision for long-acting injectables that may also be able to sustain folks as well.
We're able to do so. We just introduced our second one just the past couple of weeks. So there's a wide menu that we have available to them. Yeah.
Thank you.
Clerk Tabak.
So appreciate all the work and the presentation. And this can be offline, but was curious about the relationship with public health and with Dr. Joshi, and what's the strategy there and the approach? Because it seems to me that there's
Dr. Yoshi is my palsy. We get along really, really well. So in whatever way we can collaborate, part of what you're going to see in some of the slides here is going to give you an indication of where some of our clients are. Dr. Yoshi's been chomping at the bit to get our demographic breakup, specifically geographic breakup, because it gives us a sense for what it is. We do have a relationship with public health. Frankly speaking, we're an extension of public health in the jail. Our role is to provide public health guidance, provide public health direction. We deal with the epidemiological aspect of it. We do have a relationship with our public health department, but we also have a public health in the city of Chicago, which is also from a jurisdiction perspective, which deals with some of our issues. So we have that dual relationship.
Thank you.
You're
What
welcome.
percent, Matt,
Last question, please.
Okay.
Yeah.
what percent of the 40% actually have county care? Approximately, you may not know the hard number.
I believe in total, we have folks that are coming in with probably about a 15 to 20% opportunity for Medicaid application. There's a variety of other folks with different Medicaid plans. I don't have that specificity, but I'll be happy to get it for you.
No.
Well, actually, that's the question I wanted to ask is, are you saying that 20% of the, patients are not, on Medicaid when they come in, but they're eligible?
Yes, and again, I don't want to misquote.
Yeah.
I'll have to validate.
Well, whatever the percentage is, what's the support you give them to become Medicaid enrolled before they reenter the community so that they have that resource and it's much easier?
We have embedded in our organization, again, which is unique to us. Some of our county care folks that actually screen for your applicability. If you're applicable for Medicaid and you're not enrolled anywhere else, we begin the application.
Good.
Unfortunately, currently, we cannot file an application until you're released from the facility. So that's where our county care folks follow up with them. But we have, and we do that. We've been doing this probably for about 10 years.
And I was curious about the role that, not necessarily just county care, because I love what I'm hearing, that you're able to hand them off, and then the work that needs to be done to complete the eligibility is completed. But what about with the other MCOs that a patient is already assigned to and elects to continue to be insured by that MCO with respect to the care? So when we talk about these gaps, I mean, MCO, and you said, and doctor, you said it's about care coordination. I mean, that's what the MCOs are paid to do, is to provide care coordination, irrespective of the acuity of the patient. So that information going back into a reentry situation would be of value, I would think, to the MCO. So what does that look like, that interface between handing the patient off back into the community to the MCO that was serving them anyway, that's providing the care coordination?
You're sitting in my chair looking forward. This is exactly what we're describing with the 1115 waiver, because those relationships factually are obligatory for us to address. We're sitting with the state at their direction on what does this look like for county care, for all the other MCOs, and how do we maintain that case management and that continuity upon discharge. The 1115 waiver for us specifically focuses on reentry. That's what it will actually address for us. And it's unique in that, I'm getting a little bit ahead of the presentation, is that allows us to potentially bill Medicaid for the services that are there, or receive Medicaid funding for the services that are there. For our patients, county care patients, but also for the MCOs that are out there obligatory to their continuing for services, and for reentry services that are happening there, the care coordination. Key is care coordination for these patients.
I appreciate. Probably get to it later, but could you explain what an 1115 waiver is?
Sure.
What allows you to do?
The 1115 waiver is an exception which allows for a variety of services, not only corrections health, but for us, it allows us to look at Medicaid funding for services specifically in corrections for reentry services. 90 days pre-discharge from the jail, we will be able to look to see how we can make sure we leverage to be able to connect that patient, not only for the time they're in the facility, but to connect them back out to exactly what you all are describing. How do we connect them back to the community? How do we connect them back to a partner? How do we connect them back to eradication? How do we connect them back to the right partners, because they're in a different managed care organization? That's what 1115 is. It is an exemption. We have never been able to source revenue to be able to do this, so we frankly were an unfunded mandate. This allows us to take and do a paradigm shift on how we've done things. I thank the system because they've afforded us the opportunity, and you all, and the county commissioners, and the citizens of the county, because we are providing the services with, frankly, the non-funding source. This provides us potentially a funding source to do that. And it's still in its infancy. We do not have a timeline on when it begins. A lot of it is mandated on what the federal guidelines are going to allow us to do. Those conversations are ongoing. We have assurances from the state that this is still moving forward, so we're progressing forward with that in mind. Even if the 1115 waiver wasn't in here, we would have to do some of the things because we understand the needs for patients returning back.
So more broadly, it's, section 1115 in the Social Security Act. It allows us to do test projects, around Medicaid. And so like food insecurity, housing, all of those types of things that have been, kind of worked on over the last few years, those have all been through waiver programs. I believe County Care actually started with an 1115 waiver as well. The concern right now, not to kind of, it's been a wonderful discussion. I don't want to dampen the mood, but, Dr. Oz, has shared that there's a lot of kind of pulling back on a lot of these waivers. They won't be renewing them for social service supports, any type of Medicaid funded, employment, funding.
Just think about that sentence.
Yeah.
Dr. Oz.
Right? Here we are. Right? So yeah, I'm hopeful that this will be viewed not as a social service program, but as healthcare, and that it'll be allowed to proceed. But there's a little bit, I think, now of additional uncertainty because of all of those announcements coming out at the end.
So, man, I'm going to ask that we move forward because we've spent the appropriate amount of time on this, please. Thank you.
Next slide, please. I'm going to surprise you now where our patients are coming from. It's for the south and west side. This is the breakup by zip code on where our patient population is at the jail. It's the information that we have from the registrations at the jail in 2023. Not surprising, the area on the top left is in proximity to the jail, and the red highlights the high level of concentration, so on and so forth. But it indicates to us where we have our patients coming from. Next slide, please. This is really quickly hitting on the introduction of bail reform in September of 2023. Our average daily census, and God bless me, I'm getting older now, so my eyes are getting worse. It was at approximately 5,800 for the first, the 22 months before jail bail reform. Subsequent, you can see the number has shifted to the average being for the 22 months after bail reform at 5,100. But you can see the curve coming up. We hit 5,900 people in the jail, multiple times over the last 2 months. So we can see the census increasing. You also have on the graph on the right just the decrease in population commensurate to the introduction of bail reform. I show you the graphs because the two circled ones are our highest level of acuity patients. Even though the patient population, even in numbers, have gone down for all the levels, the P4s and the M4s remain the same, and if not, have increased slightly, which means that the patients that we have in the facility are a little bit more acutely ill, both in medical and mental health. So the population shift, although it decreases, we just have sicker patients in the jail. Next slide, please. This is talking about the 1115. We talked about it a little bit. We can continue at a different point in time in the future, but it allows us to potentially bill for services that we have providing in the facility with 90-day pre-discharge. It focuses on case management, medication-assisted treatment, prescription medication, diagnostic services, health-related needs. Some of the items that folks have addressed here in the room. The eligibility criteria is that you're Medicaid eligible individuals and you're released 90 days pre-release. Impact on us, we are doing some of the work already. We're enrolling folks on Medicaid. We're assessing what Medicaid services or what Medicaid CMOs are aligned with our patients. But it also allows us to enhance that case management component that I keep hearing here, that connection, that warm, that soft handoff. The Medicaid 1115 waiver potentially allows us to augment that role that we have a need for in the organization. We recognize it. We are within our budgetary alignment now, looking to see how we source that up. But 1115 potentially offers that opportunity. But again, regardless of what comes down the pipe with 1115, we understand the need and we understand the requirement for us to do right by our patients.
I think regardless of what happens, it's cutting edge thinking to really close that gap. But I think my position stays that once they hit the community, the MCOs should be wrapping themselves around them.
Mm-hmm.
Because that's what they're paid to do.
Agreed. Thank you.
I appreciate how you're going about it because you see the gap there. Is that
That's it. We were gonna open up for questions. We clearly had questions throughout the presentation, but if there's any additional ones, please feel
I
free.
don't think we were shy about asking throughout, but I will say a couple minutes if there's any, last few questions.
I think not necessarily a question,
Sure.
but just, I know it's on your radar. I was gonna say it, and then Director Soro also mentioned it. So I think 1115 waiver was supposed to be in place to 2029, but I think there may be recent, pushes to get rid of it, you know? So while it does allow us to, form, better customized service delivery, social determinants of health, actually, support around the people we serve, how do we build out, more case to build out those bridge services that we maybe have more insight into internally? I don't know if I hammered home the point. While those systems were in place, both at our internal linkage, which is the core center, and one of our externals, which was the F2HC I was at, certainly, I don't know if you can pull the numbers or take a look at it, there was a greater percentage of direct linkage and success and continuity of care when we had, like you mentioned to, I don't remember which director here, when we had internal access to the medical chart, access to the discharge information, and access to appointment building and support for the patient than there was at the external place.
Just a commentary on that. Craig Williams also has to be a colleague of mine, and he's working closely with me, not only with specialty. My hope is that ambulatory, which we have a really wonderful, they're near and dear to my heart. I lived that life for many years. And I was there when we had the receiving appointments in the respective community clinics. I believe they're still there.
So the same thing for mental and behavioral
Yes,
health
ma'am.
services.
Yes, ma'am. Maria Castillo on the other side also I'm an old timer. I know everybody at this point. And that helps us with the relationships because they understand we're sincere and we're advocates for our patients.
That's it for me. Thank you.
Okay, well, wow, what a very enthusiastic and critically important conversation to have, Manny and Doctor. Really appreciate what you do for the county and for these patients who obviously need support, not just while they're in, but when they re-enter back into the community. So thank you. A very excellent presentation.
You're very welcome. Thank you. One last thing, if anybody wants to tour, we're always anxious to, we're always willing and really proud of the work we're doing.
I will
Please let
take you
us
up
know.
on that, yeah.
Yes,
Sure it is. And also, don't beat yourself up about maturing in life. You're okay. It's okay to get old.
Thank you.
Yeah, thank you.
There is no alternative.
Right. Okay, in the interest of time, and to give Aaron a break, I'm gonna ask that we file the next report, and, we will not be going into closed session. So I will move to close the meeting. I want to wish everyone a good weekend as we enjoy these last few weeks of, summer, and appreciate all the great work that the county is doing on behalf of Cook County residents. Thank you. And
We still
have a
almost
good
have a
weekend.
month of summer.
I know.
Realize.
Right.
In Chicago.
Thank you, Bob.
It's over.
Thank you for being optimistic. Thank you.
Joyce sent you an email. Thank you.